Manual techniques for shoulder and rib cage mobilization, a detailed guide for practitioners. The rib cage and shoulder girdle are tightly interconnected, both anatomically and biomechanically. This section presents key osteopathic and chiropractic manipulation techniques for improving rib motion and thoracic function, all while respecting patient safety and practitioner ergonomics. These techniques are especially useful for addressing restrictions between ribs 2 and 10 and can be adapted based on the patient's condition and presentation. Ribs 2 through 5, patient position, practitioner position, standing on the contralateral side of the target rib. Procedure: 1. Locate the rib angle or costotransverse joint at the desired level. 2. Use a pisiform contact with your lower hand directly over the rib segment. 3. Remove any slack in the skin and fascia by gliding the soft tissues in the direction of the manipulation. 4. Place your upper hand over the contact hand, locking your elbows. 5. Ask the patient to inhale deeply, then exhale. Follow the rib's downward motion during expiration. 6. At the end of exhalation, apply a high-velocity, low-amplitude HVLA thrust through your legs in a direct posterior to anterior PA direction toward the table. Key points. Use a relaxed arm position and avoid any recoil before thrusting. Patient breathing is crucial in localizing motion. Excessive preload can cause discomfort and reflexive guarding. Apply only moderate tension. Prone rib technique with ACES contact. Indication: ribs 3 to 10, patient position. Prone, practitioner position, standing on the same side as the rib to be manipulated in an asymmetrical stance. Procedure: 1. Stabilize the patient's anterior superior iliac spine, ACES, with your inferior hand. 2. With the superior hand, contact the rib angle. 3. During the exhalation phase of breathing, begin to rotate the patient's trunk by pulling the ACES toward yourself while applying downward pressure on the rib. 4. Engage the barrier, then apply a simultaneous HVLA thrust. Superior hand applies PA force, inferior hand pulls AP on the ACES. Key points. Use body mechanics to generate force, especially by lunging into the thrust. The higher the rib, the more fascial slack must be managed. Be mindful of the rhythm of the patient's breathing. Manipulation should synchronize with expiration. Supine contralateral rib contact. Indication: ribs 2 to 10. Patient position: supine. Practitioner position: standing beside the patient in an asymmetrical stance. Procedure: 1. Ask the patient to cross their arms in a V formation. 2. Reach across to contact the patient's opposite scapula with your inside hand and roll the patient slightly toward you. 3. Palpate and locate the rib angle, then place a fist or thenar contact over it. 4. Ask the patient to inhale. During exhalation, gently roll them back over your contact hand so the dorsal surface rests against the table. 5. Position the patient's arms above your contact point. 6. When the contact hand is sufficiently compressed and the barrier is engaged, apply a downward thrust using your legs and hips. Key points. Scapular clearance is essential for accessing the ribs. Arm positioning is crucial. Do not initiate the thrust prematurely. Ensure you've reached full tissue tension. Maintain spinal alignment and use your hips to drive the motion, not your arms. Seated rolling rib manipulation. Ipsilateral contact. Indication: ribs 2 to 10. Patient position. Seated, practitioner position, standing on the same side as the rib to be mobilized. Procedure: 1. Guide the patient to raise the ipsilateral arm overhead, placing the hand behind the neck. 2. The contralateral arm is crossed underneath, hand covering the axilla. 3. Step forward with the leg closest to the contact side, e.g. left leg forward if working on left ribs. 4. Reach over the patient's shoulder with your inside hand and establish a thenar contact over the rib angle. 5. Secure the patient's upper body by pressing their elbow into your chest using the same arm. 6. Ask the patient to relax into a slumped posture and take a deep breath. 7. During exhalation, roll the patient down and forward onto your contact hand while lunging forward. 8. Apply a controlled HVLA thrust in an anterior to posterior direction using your body weight. Key points. Raising the arm clears the scapula and improves access to the rib. Avoid excessive loading, as too much pressure can provoke a guarding response. The manipulation should feel like a continuation of the natural breathing rhythm. Alternative version. For supine application, reverse the contact using the radial border of your contact hand along the medial scapular border. The technique sequence remains unchanged. Seated rotational rib manipulation. Indication: ribs 3 to 10, patient position, seated with arms crossed. Practitioner position, standing behind the patient. Procedure: 1. Instruct the patient to cross their arms in a crisscross position over the chest. 2. Wrap your supporting arm around the patient to stabilize the inferior elbow. 3. With the opposite hand, palpate and locate the desired rib angle. 4. Apply a pisiform contact and take up soft tissue slack in the skin and fascia. 5. Position your elbow low to create an inferior to superior direction of drive. 6. Ask the patient to inhale and exhale. 7. Rotate the patient away from the contact side, maintaining contact with your shoulder and elbow. 8. Once at the barrier, thrust obliquely through the rib using your whole body in a coordinated motion. Key points. Stability comes from your body contact. Ensure the patient feels secure. The thrust should be oblique and follow the natural motion barrier. Use a coordinated rotation rather than isolated arm pressure. Clinical considerations. These techniques require high-level palpatory skill and an understanding of rib and scapular biomechanics. Always ensure the patient is relaxed and comfortable before any thrust. Breathing cycles are respected to optimize tissue tension. Communication with the patient is ongoing throughout. Contraindications include acute trauma, fractures, severe osteoporosis, recent surgeries, and any red flags such as systemic infection or neoplasms. Always screen thoroughly prior to applying these techniques. By mastering these rib and shoulder mobilization methods, manual therapists can significantly improve thoracic mobility, address musculoskeletal restrictions, and alleviate discomfort in patients with postural or functional imbalances. Integrating breath, positioning, and leverage ensures that each technique remains both effective and safe. Key clinical insights. Optimal rib angle access. Cross the patient's arms across their chest to retract the scapula and allow clear palpation of the rib angles beneath. Breathing and tissue tension. Patient respiration and proper management of skin slack are essential for precise localization of rib motion and for maintaining a stable contact throughout the technique. Secure upper limb positioning. Ensure the patient's elbow and your contact with it remain firmly stabilized. This connection is crucial for transmitting the mobilization force effectively into the rib articulation. Ergonomic setup. Position the patient closer to the rear edge of the treatment bench. This minimizes the need for the practitioner to overreach and enhances mechanical efficiency. Use of body mechanics. Generate thrust,